Boston's Brigham and Women's Hospital has been a destination for advanced health care for nearly 2 centuries. Consistently ranked one of the country's top hospitals by U.S. News and World Report, men and women come here from across the U.S. and from over 120 countries worldwide. A long-standing teaching affiliate of Harvard Medical School, the Brigham is home to profound, life-giving breakthroughs, like the world's first organ transplant, and continues this today with new ways to prevent disease and to maintain health. The Brigham is a biomedical powerhouse. Its discoveries affect all of us, such as the impact of a daily aspirin in preventing heart attack and deciphering the role of amyloid protein in Alzheimer's disease. And the Brigham is dedicated to training the next generation of healthcare providers. Many of our clinicians and alumni are leaders in medicine today, transforming the future of healthcare to improve lives everywhere. Learn more at brighamandwomens.org.
We're going to move on to the next panel, which is one by Brigham, and certainly one that I've been looking forward, as I have with all of them. And it's going to be moderated by Dr. Mark Davis, who is Vice President of Brigham Health International and Executive Director of Business Development and Strategic Initiatives. So with that, I welcome Dr. Sawsan, Dr. Laskowski, I hope I said that right, and Dr. Goralnick. So with that, Mark, please take it away.
Good morning, good evening to everyone. I'll begin just briefly by thanking Ransel for putting together another terrific conference in difficult circumstances. I wish we could all be together. We will be together soon. And really also want to thank Sawsan, MSK, and for all the others who have worked hard to make this happen. We have a really terrific panel today. So I won't delay our getting into it. The goal here is to share some of the lessons learned as we've prepared and addressed the situation with COVID. I'll introduce each of our panelists very briefly and more extensively as we get to their individual conversations, and we'll try to have a group conversation. And I'd love to make this as interactive as possible, so hopefully we'll leave some time at the end. As you can see, we have 3 really distinguished panelists with us here today. Dr. Sawsan Madhi, who is well known to many of us, really terrific to have her join us on this panel, talking about cancer care in particular. Dr. Eric Goralnick, one of my long-term colleagues at the Brigham, and likewise Dr. Karl Laskowski. Thank you all for making the time today. I'll begin by introducing Dr. Goralnick, who is going to speak about lessons learned in preparing large healthcare systems. Dr. Goralnick is Medical Director for Emergency Preparedness and Access Center at Brigham Health. He's responsible for system-wide efforts to prepare, mitigate, respond, and recover from disasters, in addition to coordination of all outside hospital transfers. He's in the Department of Emergency Medicine. He's the medical director for Gillette Stadium for New England Patriots football games. And of course, we miss our quarterback, although we're very happy with our new one as well. Dr. Goralnick is very active in emergency preparedness. He's a US Navy vet, is a featured speaker all over the world, and a very good friend. Dr. Goralnick.
Thanks, Mark. I'm going to go ahead and share my screen.
Please.
And I noticed that Mark introduced me as his long-term colleague. I don't know if that's positive or negative, but it's definitely long-term. So thanks, Mark. So in about 10 minutes, I'm really going to focus us on 5 key learning points around preparing your healthcare system, our healthcare systems, for an epidemic in real time, building on the concept of a learning health system. What's emergency management? So right now we're in this world where COVID is on everybody's mind right now. Obviously, we're in the largest pandemic since 1918. And there is a concept and a whole profession called emergency management, which really focuses on things like pandemics, things like bombings and shootings and computer systems downtimes and cyber attacks. And in fact, it really focuses on 4 core functions or phases, which is prevention, mitigation, response, and recovery. Each of those is equally important as we are thinking about these types of events. So right now, we're really in the response phase. We spent decades preparing for this. We had some interventions around mitigation, and depending upon where you are in the world, we're in somewhat of a response, somewhat of recovery, and we'll go sort of back and forth in this prolonged event. So 5 key principles I want to talk about in the next couple of minutes around emergency preparedness and emergency management. One is defining the mission. So these were our numbers at the beginning, or actually towards the end of January 21st. In the United States, there were 15 positive patients. Sadly, yesterday, we marked 200,000 deaths in the United States. The United States makes up 4% of the world's population, yet we're responsible for 25% of deaths in the world. So you could see that this ramped up significantly over the course of the last 8 months. And when it really became real for us, right at the end of February, the last week of February, we started to ramp up our response, and we defined our mission from the outset, which was not to just take care of COVID patients, but to ensure we maintain open access for non-COVID patients, right? Because we've got to take care of the strokes and the heart attacks and all the other disease that can walk in our door, and ensure that people are getting high quality, safe care throughout. So that was a critical piece of defining our mission from the outset, because people have the intent of focusing just on the threat in front of you, which was COVID. And at the end of February, if you remember, Biogen, which is a large pharmaceutical company, at their Cambridge hospitals at a hotel right across the river here, had a large conference. And within 3 or 4 days, when they had people from all around the globe come to this conference, within 3 or 4 days, people started showing some signs and symptoms of COVID. So we were called at the Brigham along with Mass General, and we had a conference call with the leaders of the Department of Public Health within the Boston Public Health and Massachusetts Department of Public Health. And they said, look, we have several hundred people that need to get tested. How can we do this? And there was a burning platform. So with our agenda in mind, with our focus and our mission, we gathered in the room. Karl Laskowski, who's going to join us shortly, is one of those leaders that joined us. And we focused our efforts to basically build a drive-through in our emergency ambulance bay so that we could accommodate over 100 patients within 72 hours, middle-aged, elderly, pediatrics, so children. So children were already starting to show signs and symptoms because they were around family members that attended this conference. And within a matter of hours, we really stood up something we had never done before, which traditionally would take quite some time to establish at an institution like Brigham Women's Hospital. So one was define the mission and have a burning platform to execute on the mission. 2 is organize your team. So in emergency management, we've learned a lot over the last 50 years. And really the story begins around this concept of the incident command system. And there are versions of this all over the world. But our version really began in the early 1970s, where there were wildfires similar to what we're experiencing today in California and Oregon and other states, where these wildfires went across state lines. And in the after action review, what we learned from this event is that there are many different agencies, firefighting agencies, law enforcement, other public safety professionals responding, and they couldn't really communicate to each other. They were using different codes, different language, different leadership organization structure, different protocols, and this caused a lot of confusion and really led to some preventable events during these fires, significant fires in the early 70s. So there was a group that was commissioned called FireScope along with RAND and aerospace engineers. They looked at this and they established what was called the incident command system. So the incident command system is really providing a structure that has an organization that provides role clarity, consistent nomenclature, unity of command, a reasonable span of control, and that is both expandable and contractible. So the concept is you have an incident commander who has oversight and overall responsibility. There are 4 what are called section chiefs, the operations section, who are the doers, the people that are responsible for the current operations, everything that needs to be that's happening now. The planning section, which are the thinkers, those individuals that are saying, okay, over the next 24 hours, 48 hours, 1 week, 2 weeks, 1 month, what are the things that we need to think about? We need to set the objectives for this time frame. And then the operations section, they execute on those objectives that were set up by planning, logistics, supporting all of the supplies, space, issues responsible, and of course, finance section, you've got to have quick access to funding for this. So what it provides is really some organization and role clarity during an event, during a crisis. And then in 1982, there was a crash in the Potomac River, that an aircraft crashed into a river that borders both Washington, D.C., Virginia, Maryland, and it was similar to those wildfires, right? So the idea that you have multiple agencies and almost everybody perished in that crash. And these were all, almost all of them, preventable deaths, right? Because we had real challenges on communication and getting to these individuals that were in the freezing cold water. So during their after action review, they recognized that the ICS, or Incident Command System, was a viable option. The Incident Command System spread from the West Coast to the East Coast. It started to develop over time in the 1980s. In the late 1980s, it became a standard within the healthcare industry called the Hospital Incident Command System. And then post 9/11 in 2004, it became a standard across all industries called the National Incident Management System, and there was a recent revision. So really, it took over 30 years for this to become a standard in the United States. And we've used this for a variety of different events, from our Boston Marathon bombing in 2013 to our Ebola preparations in 2014-15, to Snowmageddon, which was major blizzards in 2015, January 2015, to an active shooter that we've had. We use the same expandable and contractile system so that we can work together and everybody can have some role clarity, responsibility, authority, and accountability to execute in short order. And this was our HIC structure that we used during the most recent event during COVID. Principle number 3 is acquire data. Let's get some data. And by the way, multiple anecdotes do not equal data. So we learned pretty early on during this event that there were significant disparities, and this is a predictable surprise. We can see this from prior disasters, whether it's Hurricane Sandy, Katrina, other major events. We could see that vulnerable populations are unfortunately impacted much more significantly than those who regularly are able to access healthcare. And in the city of Boston, we saw some real striking numbers pretty early on, which is very sad for multiple reasons. But that's an opportunity, and this has been an opportunity for recognize that there are populations that are vulnerable, Black and brown populations, those with disabilities, and we've got to focus like a laser beam on mitigating these issues, not during the event, but really during the event, and then thinking about this, what are the lessons to learn from for the long haul. Now, that brings us to the 4th point, which is to act on that data. So we gather this data, we're reporting out on a daily, sometimes multiple daily basis with our Hospital Incident Command team. We gather information on hospitalizations, presentations, ambulatory volume, which I'm sure Dr. Laskowski will address. And we really started to focus on the bottom right on health equity indicators, because this should be part of our work. It traditionally has been something on the side. There's an Office of Diversity, Equity, and Inclusion, but this really is the heart of the matter. And us having a focus on this, building a team around this, really helped us start to define and understand the real issues with our most vulnerable populations. And so leaders like Cheryl Clark, Sunny Eapen, and others, who's our CMO and our leader for our Diversity, Equity, and Inclusion Task Force, they established various different nodes where we reached out to the community, did a variety of different testing, access to food, and other resources, along with bridging the gap on a variety of different issues here to address diversity, equity, and inclusion during the event. These are some of the numbers about our community outreach led by some of these leaders like Tracy Sylvan, Kristen Price, and Bernie Jones. And finally, perfection is the enemy of the good. So former General Commander of the Joint Chiefs of Staff and our Secretary of State, Colin Powell, used to use the term the 40-70 rule, which is P equals 40 to 70. So P stands for the probability of success, and the numbers indicate the percentage of information acquired. Once the information is a 40-70 range, go with your gut. The reality is we rely on perfection. We're always trying to get that perfect randomized control trial, but during a disaster, we've got to do the best we can with the information that's to bear. Don't make premature decisions before you have 40% of the information, but don't wait till you have 70% of the information to make the best decision you can, and surround yourself with expertise and do the best you can throughout these events. So in summary, define the mission, organize your team, get data, act on that data, and remember General Powell's 40-70 rule. Thanks so much. I'll turn it over to Dr. Davis.
Dr. Goralnick, thank you. Terrific as always. I'd like to introduce our second panelist, who will be speaking on international patient care in the time of COVID, challenges, successes, and lessons learned. Dr. Sawsan Madhi has more than 16 years progressive leadership skills and experience in strategy, operations, and administration of the nonprofit charitable sector. Currently, she's working with one of the most reputable charities in the UAE as the Director General for Friends of Cancer Patients. Dr. Sawsan's role is to supervise the continuing refinement and expansion of the organizational objectives, which include providing high-quality services, organizing fundraising activities, developing, planning, and executing nationwide awareness programs and campaigns through collaboration with a vast network of national and international government and private sector organizations. Her CV goes on, but I will just mention briefly that she's an internal medicine specialist, fellow of the Royal Society of Medicine in London, and a registered doctor with the General Medical Council in the United Kingdom. Her clinical and medical expertise is based on working at Dubai Health Authority in the Ministry of Health in Sharjah, the UAE. So without further ado, Dr. Madhi, thank you for being here.
Thank you, Dr. Mark, for this introduction. And also, I'm very privileged to be a part of this panel and with my esteemed colleagues as well. I couldn't agree more with the presentation presented by Dr. Eric right now. Going through the COVID-19 experience, which we're all still going through, I believe we have learned a lot, and the lesson that we have learned is just gearing us to the future, which is what is the norm going to look like, of course, working especially with patients. Maybe in the panel, I carry the voice of the patients here. And I think the most important thing is to always remember, we always say patient centricity, but what does that mean from a patient perspective? And I think that is very important. Before I start, I would like to give 5 minutes, if I'm allowed, to just speak about Friends of Cancer Patient and what we do. Although we are a very much UAE-based organization, we focus on 3 pillars and three objectives. So the first pillar is very much around patient access, either access to treatment or access for quality healthcare, and also access to moral and psychological support for the patient and their family. And this is what we do with the patients and their families. The second objective that we work on, and the second pillar, is very much community focused. We educate the community about early detectable cancers. We advocate around screening program. We even went to the extreme of actually providing or being the first NGO in our region to actually provide a well-structured screening program that provides a whole solution for breast cancer screening. We have now a mobile mammogram van that provides both mobile technology testing for breast cancer, but also does pap smears to detect cervical cancer as well. The third pillar that we work on is definitely advocacy, and through our advocacy work, we highlighted the importance of patient voice on a national level. We sit on lots of Ministry of Health committees, either speaking about reducing cancer mortality or even speaking about reducing NCDs in general in the United Arab Emirates. But also our advocacy extends beyond. We have very much a great global advocacy portfolio. We host the Global Non-Communicable Disease Alliance Forum every 2 years. And also we're a member of the UICC, and we have a lot of projects going on globally as well. Now, why is it important for me to just lay the foundation for what Friends of Cancer Patient do is because all of this work that I just spoke about got suddenly disturbed by the COVID-19. Suddenly, we cannot have access to our patient. Patient can't have access to their doctors and their hospitals. Patient rely on us for the financial support, but also I think the more reliability comes that would provide lots of social and moral support as well for those cancer patients. We had to go into lockdown in the United Arab Emirates. I think it was mid-March, and we started working till early July just at home. So I think the second thing as well is that how can we continue our community advocacy and how can we educate the community where the community, A, are also in lockdown, but B, the priority for the community is COVID. It's no longer, oh, let me listen to you. Let's talk about how can I reduce my incidence and risk factor for breast cancer or cervical cancer. It's all now COVID, COVID, COVID. We started teaching people how to wash their hands, which is something we have learned back in elementary school, actually, but we have to, again, emphasize the lesson. And the third and most important thing was how can we continue advocating and still trying to knock on policymaker door and ask them that cancer and NCDs should be still on the higher priority, where the policymakers exactly the experience in Brigham Hospital was all about, COVID. Let's test about COVID. Let's find more cases, find and isolate, because that was a UAE policy, is finding and isolate. So quite very, very interesting how we managed to turn the table. I think it was within 2 weeks that. And again, this is where I find Dr. Eric's presentation very brilliant, because literally he just put it in a very clear, systematic way. Really, you need to have a clear vision. Like he said, it's the mission, but also the clear vision. What do I want? Bear in mind, we are a self-funded organization, which means that I do rely on public to get my funding and be able to operate as any NGO. So putting all those complexity in mind, it was very important for us. And I think one of the success stories for us was, A, we were very agile. We were very flexible. We worked on an emergency policy to work from a distance, yet keeping the patient and patient centricity and being focused on the patient need. And this is where, and I think the whole conference, the C3 conference this year is just talking about innovation and technology. And this is where we went and accelerated our technology and digital portfolio. We had a 5-year plan, started from 2019, that we wanted to transform everything in Friends of Cancer Patients to be digital. And because of COVID, we actually condensed this 5-year plan into just 6 months, or actually 4 months, to be able to accommodate to all the need that the COVID and pressure that the COVID-19 put on us. And so this digital transformation didn't just come from the health perspective. Of course, most of the sessions that the esteemed colleagues and esteemed panelists talked about throughout the forum today, the summit today and yesterday, was more about technological innovation in healthcare. But also I'm talking about technological innovation when it comes to marketing as well. How did we market ourselves? How did we use the digital space, especially social media, to be able to connect to the community and be able to still send the message of advocacy there? And also, how did we package our condensed our awareness messaging and our health messages from those brochures or those lectures that we used to do, and made them online friendly, and made the utilization of platforms like Zoom and other platforms that offer meeting opportunities. This is very important, but with the positive always comes the negative. And I think that is very, very important, because lots of our patients, and I'm not just speaking about people inside the United Arab Emirates, but I kind of want to give an idea about the patient in our region as well, and I'm speaking about the Arab world, is that not all of them are digitally literate. So there's lots of illiteracy when it comes to digital technology. You know, some of them, yeah, they can use a mobile phone, but can they operate an app? Can they know how to log in on an online platform? I think that was one of the challenges. And really, this is something that we need to take in our mind when we speak about technology, because technology is very rapid, it's very fast. If I have a mobile this year, in 2 years or 3 years, the technology will have something new for me, and they will have a new upgrade. So we have to speak about technology from a feasibility point of view and from a sustainability point of view as well. And one of the major important things as well, which is really quite very important, I believe the panel before us spoke about data security. That's really very important. Now, most of the consultations that happened for patients while we were following up with our patient happened using telemedicine, which ironically lots of hospitals had. They all had this infrastructure. They all had the platform. They all had the means and the how of a telemedicine consultation. But the problem is they didn't bother because they knew the patient will come. They would not have imagined something like COVID that would prevent the patient from coming. But also, which is also a very important thing, is that policymakers and payers were never included when these infrastructure was put. So we had to do a lot of lobbying to make sure that insurance company recognize online consultation. So I know a hospital that had an online telemedicine infrastructure since they were built, which is around 7 or 8 years ago. But they never put it in their mind that this should be part of their insurer payment list, so they can actually have a code for it. So these were all kind of challenges that we had to really accelerate through in the past, since mid of March till relatively June. And all those lessons learned from the patient experience really helped us sharpen our pen or pencil into how to look forward. So next time when I sit in a committee and speak about the patient voice and the patient need, I am more informed now because these are actual life scenarios that we all have to go through to make sure that the patient are truly, that healthcare is truly patient-centered, and we are catering to the patient needs. Thank you.
Thank you very much for those very thoughtful words, Dr. Madhi. It's now a great pleasure for me to introduce one of my esteemed colleagues, a senior leader at the Brigham and Women's Hospital, Dr. Karl Laskowski, who is the Associate Chief Medical Officer. He's responsible for clinical leadership of Brigham Health's ambulatory enterprise, coordinating efforts to improve access, efficiency, quality, and value. Previously, Dr. Laskowski held several leadership roles at the Brigham and Women's Physicians Organization, focusing on population health, process improvement, and innovation. Dr. Laskowski maintains an active internal medicine practice as a graduate of Yale University School of Medicine and Harvard Business School, and it's certainly been a pleasure to work with Karl over the last number of years on many different programs and processes. He'll speak today on reorganizing ambulatory care in COVID-19 process, lessons learned, and predictions for the future. Karl.
Thanks, Mark. Can you hear me okay? I was having some trouble with my audio earlier.
Sounds good.
Great. Let me share my screen here. All right. So as Mark talked about, I'll talk a little bit about the challenge of managing ambulatory care in a pandemic, which is something we had not had to deal with before, and I hope we will never have to deal with again. But I think there are a lot of really great lessons that several of the speakers have already alluded to already. COVID really started quite early in Massachusetts as compared to the rest of the United States, and Dr. Goralnick referenced the Biogen conference in February. And what you see here is a graphic from the New York Times looking at new reported COVID cases by day over the past 9 months or so. And you see a spike starting towards the end of March and really continuing through June, and then sort of a slow burn thereafter. When we initially approached this crisis, we saw it as the challenge, at least at first, of inpatient resources. We were worried about things like ventilators and hospital beds and ICU staffing and all of the things that go along with that. And sure enough, if you look at internal data looking across the Mass General Brigham system and all of our hospitals, including the 2 academic medical centers, the Brigham and MGH, what you see in terms of admissions really mirrored the diagnosed cases. So a spike starting towards the end of March and really continuing through the beginning of May. What you don't see on this graph is the tail of the admissions, because these patients tend to stay, especially the sick ones at the academic medical centers, quite a long time, upwards of 20 or 30 days. So while the admissions tailed off in May, we really weren't back down into a sustainable space until well into June and really into July. As we prepared for the inpatient surge, we really shifted our attention away purposefully from outpatient care. We needed those individuals and our staff to help out with inpatient responsibilities. We and the state and the government really wanted to limit travel and exposure starting in April. And at one point, actually, there was a mandated pause in elective procedures and visits and all the things that didn't actually need to be done. So what you saw in our ambulatory data was somewhat predictable, where the volume, what we usually do around 200,000 visits a month, cratered to somewhere around 50,000 a month. And some of that was our own purposeful decision to push these appointments and visits back. Some of it was patient apprehension about coming into our facilities, largely located in hospitals. And some was just a lack of resources and the overall kind of confusion in the midst of a pandemic. The other thing you'll see is a rapid switch to virtual care, and Dr. Madhi referenced this as something that didn't really happen for lots of hospitals until the pandemic, and we're not alone in that regards. We had some infrastructure. We did a smattering of virtual visits, mostly video visits via Zoom or a similar technology. And we did about 300 or 400 a month, a tiny volume compared to 200,000 in-person visits. As the pandemic picked up speed and we were unable to see patients in person, many of these patients still needed to get ongoing care, and we rapidly transitioned to a virtual infrastructure that was much more robust, and we're doing about 60,000 visits per month by mid-April, which is dramatically different from where we started, and we represented initially about 50% of our volume. As we've come out into kind of a more sustainable phase of the pandemic, hopefully not a pause between 2 surges, but the end of the surge for the time being, we have regained the ability to see patients in person, and virtual care has fallen off a little bit as a percentage of the total to about 20 to 25% each month, still representing about 40 to 50,000 visits. And our total volume is about the same as when we started, and many weeks actually above where we had started all this, representing some of that pent-up demand, and our institution getting much better at being able to juggle virtual and in-person care and really extend the way we deliver care. Through this, I think there were 5 themes that we noticed across the ambulatory enterprise. The first was a recognition that the responses we came out of the emergency preparedness incident command structure that Eric was talking about in the beginning felt a bit reactive. COVID has been very challenging. We learn a new thing seemingly every day. Our kind of knowledge about how to deal with the disease and our rules about what we should be doing are changing, and that's very unsettling. And while the emergency preparedness structure really helped us do that in a meaningful, solid, and understandable way, as we reverted to kind of more normal operations, it felt a little bit more like we were reacting to COVID rather than planning for the future. I think the challenge as we've resumed normal operations is to take this reactive planning and make it into something that feels more flexible. It is proactive, but able to change when we learn new things about the virus, when the situation changes, or when kind of new needs arise. And that is an ongoing process that we've tried to manage within our usual operating structure, but something that's been honestly quite challenging. The second theme across the ambulatory enterprise is how do we return to in-person visits and make people feel safe? And this is a huge challenge. To be able to see 150,000 patients a month, people need to feel like they can come to the hospital and are not at risk of getting infected, and that people are really taking this seriously. One of the big things that we've put into place is screening patients prior to visits, and this is about making our staff feel safe and our patients feel safe, and adopting a range of tools to get this to happen. So we ask every employee since March, every morning you have to fill out an app that says, do you have any symptoms that would be consistent with COVID? And actually lists those on the screen, and you fill out no, and then you kind of show that pass as you come in. And we've been asking those same questions to our patients, initially by phone, and then building it into our electronic medical record system where they get a message via email 2 or 3 days ahead of their visit to fill out. And now you can use a very similar version of the app to certify that they don't have any symptoms on the day they are coming in. And we are greeted by someone at the door to verify that they have either done that or they ask them those questions live and again at the clinic door. So lots of kind of repetition. It feels a little bit like we're doing something more than once, but that's by design to try to make sure that people feel safe and that staff feel safe coming to work as well. And then we also have masks. I'm sitting here in my clinic office, but no one's here. When I go to see patients, we all wear surgical masks 100% of the time. Patients wear surgical masks 100% of the time. And we found that has limited the kind of spread of COVID within the institution, and really have not identified a single case since we instituted that rule back in March. But there's a signaling aspect to that as well. It's not just the actual act of protection, but the feeling that patients and staff get that we are taking this seriously and we are here to kind of make you safe, and the messaging that goes along with it. The third theme that we've seen across the ambulatory enterprise really is around that virtual care that I referenced earlier. And it took off because we had no other choice. We could not see patients in person. What we're finding as we revert to a more normal operations is we need to optimize this. The big work over the next 6 months that the ambulatory team here is focused on is around figuring out how to integrate it appropriately into everything else that we do, and how to make sure it's safe and efficient. So things like, how do you room patients? Everyone knows how to room patients in a clinic. The staff take them to the room, you get their vital signs, you do all the normal things that you would do. What do you do when a patient is at home and they're coming on to a Zoom call? Initially, we didn't do anything, and that we learned quite quickly was a mistake, and that there needs to be kind of a process around that like much of anything else. Similarly, when they leave the visit, there are often tests or follow-up things that need to happen. And because we started so quickly, did not necessarily have a process around that or a thought about what is the appropriate way to make sure those things happen when there is this geographical divide between the patient and the clinician seeing that patient. Finally, in virtual care, we really want to think about what are the right diagnoses and patients and visit types for this care in person versus virtual. We're experimenting to a certain degree to try to figure that out. We were forced to see all patients virtually, which we realized is not ideal for some patients. There's some who need a procedure or a physical exam who should be coming in, but it is certainly more convenient for those patients that don't need those things, and kind of safer for everybody, and allows us to space out patients in the physical clinics when we can do so. And there's a lot of work amongst the departments here to figure out how do we codify that? How do we really make sure that we have thoughtfully approached this and decided who should be here in person, who should be at home, and how do we make those decisions going forward? The last two themes that I'll talk about briefly are really this is thinking around a centralized versus a distributed approach to how we deliver care. As we've shifted roughly 20 to 30% of our volume to virtual, we have all these physical assets, big buildings full of clinic space that we need to figure out what to do with. And we may not need as much physical space. This is a little bit of a challenge for us at the moment in that we need to space out patients as well. So we need more space to do the same things we were doing before, but we probably don't need as much space as we had. And thinking about, do we centralize some of this care in a way that allows us to get rid of space and be more efficient? And what are the implications on patient convenience and geography and the ability to access our care if we were to do that? And that's still an active effort in planning. Similarly, in thinking about how we care for respiratory patients, patients with COVID symptoms or flu symptoms or something that could be a respiratory disease, initially we centralized that care. We put it in dedicated respiratory clinics and tried to consolidate staff and make sure that it was controlled, and we really understood how patients were getting in and out and safely accessing the facilities. As we've transitioned back to a more distributed enterprise, we have chosen to distribute the respiratory care as well and push it back into the clinics, which initially was a little bit uncomfortable for folks, trying to figure out, how am I going to see a potential COVID patient in my own clinic? Do we have the appropriate PPE? Do we have the appropriate process? But we felt that there was important for a couple reasons. One, we needed the space back to do things in it that usually happened there. So many of these respiratory clinics took over space that was underutilized because we had stopped doing other things. And that was no longer a viable option as we resumed regular care. And patients didn't want to drive all the way to downtown Boston from very far outside areas of the state to access care if they could get it closer to home. So we felt like we could do it in a safe way and wanted to very much be convenient for patients. And also, there is this problem with COVID that not everyone recognizes symptoms or even has symptoms. So we worried that if we kept these respiratory clinics kind of centralized, it would give us a false sense of security. We would think that we had contained and segregated COVID into these few clinics where everyone was very conscious about the PPE and appropriate precautions, whereas COVID could be the next patient walking in the door, and we really need to treat every single patient as if they have some infectious risk to keep our patients and each other safe. The last thing I'll briefly touch on is really around testing strategy. And this is another one that has evolved over the course of the pandemic and something that's central to our ability to be able to continue operating both in an ambulatory enterprise and inpatient, but most of the testing happens on the outpatient side. The short version of the testing strategy is that we're looking for more, and that is basically it. Initially, we started testing in space that was used for other things, much like the respiratory clinics. Eric showed you some pictures of the ambulance bay, where we turned a parking area for ambulances into a testing center for patients who needed COVID testing, and were able to swab them as they drove through. The other testing areas were similar. They were often outdoors, which presents some challenges in terms of heat, and in Boston, with winter coming, cold and snow. And we had limited supplies. We weren't able to test as much as we wanted to. So we had very strict criteria for who was able to access testing and how we would divvy up the ability to test patients and make sure that we were getting the patients who really needed to be tested. As we have found additional resources, we've expanded our testing criteria and really don't restrict it much at all at this point, and expanded sites. So we have about 15 sites across the state, and they vary in physical structure from drive-throughs to clinics where people would walk in to try to make the spaces more permanent, more widely available, and really focus on the efficiency of both the testing process and the turnaround in the lab, which initially took days and now takes hours. But it is something that many of our physicians and staff are kind of fixated on. How do we get even faster testing, even more widely available, and even easier to access? And something that we need to be able to kind of operate the ambulatory enterprise and kind of make people feel safe. So those are the kind of major themes as we've worked through the pandemic. And I'll hand it back to Mark and save some time for questions and dialogue here.
Thank you, Karl, for a really interesting presentation. I appreciate my colleagues for their insights and also being right on time. So as we go into some questions, I'd love anybody who has a question in the audience, please type it along. Happy to put it forth. I want to say one quick word, and Ransel mentioned this at the very beginning as he spoke about C3, spoke about President Clinton's vision, his vision. We will be having, as a part of this, an enormous group of colleagues from China listening and ultimately participating in this conference, those from all over the world. Those of us who have been involved in global health understand that healthcare is often the language that is safe and highly productive between societies, regardless of what's going on politically. And those of us who've been doing it for a while could see the really transformational aspects of engagements like this. So I want to congratulate and thank all of my colleagues from that perspective as well, and Ransel and his leadership for it. So I'll start as we wait for questions, which I'll ask each of our panelists, and if you keep your answers brief, we'll be able to ask a few questions. But as we all address the COVID pandemic, I'm wondering what your thinking is. Dr. Goralnick, you spoke about all the planning that took place before, as did Dr. Madhi and Dr. Laskowski. Could you break down, as you think about this, what are the barriers that you, as you plan, and it's all theoretical, what are those barriers and how would you suggest that we address them as we plan, as many of the other speakers have spoken about, the future of healthcare? And then contrast that with the barriers and problems you found during adoption and during operations. So if you could go through what you think are the key aspects of how it's hard to motivate people before, and how do you motivate them to do what we all know is going to happen. And then once you get in the thick of it, how do we deal with this? And I have to say one other thing before I turn it over to our Chinese colleagues is that as COVID happened, there was tremendous collaboration between many of us on both sides, building on terrific relationships over the years, as with all the rest of the world. So Dr. Goralnick, can I start with you?
Sure. I think, the first piece is, prior to this event, how do we build a culture of preparedness? It's really quite challenging. We all have a short-term memory, and we're thinking about that thing right in front of our face. And it's really quite challenging to think through. There have been some economic analyses around this. It's almost like a life insurance policy where every dollar we spend in preparedness is worth $20 or $30 in response. Who knows what the actual formula is? It would be a good investment to try to figure that out. But what I've found is now is the opportunity to have that conversation to say, we have a framework, right? What do we need to do to build on this to maintain a certain level of capability and confidence that our operations are safe and can continue to be safe throughout COVID and beyond? What is the fee or the cost of doing business in the post-COVID world? So that's sort of part A, an investment in preparedness. And then the second point, how do we sort of maintain operations at this point? Each of our speakers spoke about some of their challenges. It's coming back. I think it's coming back to the patient, right? The patient and patient safety and our staff safety. Unfortunately, I just saw that in the last 48 hours, there was a young woman physician who passed away, a gynecologist, I believe, in the Southwest. And it's tragic. And many of these are preventable deaths. So we've got to keep focused on what we can do every single day and remain vigilant. We have to ensure that we don't get comfortable. We have to remain vigilant and keep fighting this good fight throughout this pandemic and maintain that effort of readiness for the future. Thanks.
Thank you. Dr. Madhi?
Yeah, I totally agree with Dr. Eric. And I think one of the other lessons learned as well is, of course, the bigger barrier is trying to figure out solutions in a new paradigm. It's like going into uncharted land without having with a blindfold as well. So one of the major as well barrier that was and still is that the data is so fast, you don't know what you should rely your decision on. But I think and the other barrier is that we are all humans and we thrive on social interaction. So to be honest, having the Zoom is like a godsend, at least there is that some sort of, and I'll put quote unquote social interaction, but definitely not like being face to face. And I'm sure, unfortunately, we have to bear in mind that that's going to be our reality for a fairly long time. I mean, I don't believe I'm going to be able to travel to the US for SU3 next 2021. I'm not sure, finger crossed. But I think one of the lessons learned, and I think it's very important for us to address that, is that the COVID taught us to accelerate stuff, to accelerate things. So things that, and I spoke about our 5-year digital plan that we wanted to go, very digitally, do more awareness and marketing on a bit more digital platform. We had a 5-year plan for that where we condensed it to 4 months. We still have things in the pipeline. But again, that's really a huge, a gap that we had to close. And we had to do that. So you know what? We discovered it can be done. So what else can we do to accelerate healthcare services for patients, or to accelerate, new modalities of way to do things? I'll give you a prime example. I mentioned that we have a mobile mammogram that we go from one emirate or one city to another to perform screening and mammograms. And during the lockdown, not very likely, lots of women didn't really want to, although it's very mobile. We adhere to the, all our staff with PPEs, we adhere to the, health and safety policy. But to be honest, women, their priority wasn't really to get screened at that time. Although we tried to advocate that you have to come, this is for your own good. But what happened is the Ministry of Health called us and they said, we have smaller clinic that we just use as a premises to do clinical examination. So it doesn't have any, technology inside of it, not like the big machine that has 3D tomosynthesis mammogram and a state-of-the-art ultrasound machine. So Ministry of Health said we need those because these will help us continue our services to providing important vaccination for children, but without the family being able to go inside the primary health center because we don't know who's inside that have COVID or not. So these small clinic were actually utilized by the Ministry of Health to administer the regular annual vaccine for children, which couldn't stop. I mean, you can have delayed it for 2 months, 3 months, but if the child has to have this vaccine, the child has to have this vaccine. So these kind of collaborative solutions are very important. And again, if we could have made it in COVID, I think it is possible for us to continue with this mindset. We always used to hear, oh, let's think outside the box. You know what? There's no box. There is no box. I think COVID showed us that the box was kicked outside and we really need to think with a new paradigm in mind. Also, which is very important, I was just reflecting on the title of our panel, which is Delivering World-Class Medical Care. If I tell this to any of my patients, they will say, how much will that cost me? Whenever you say world-class, people, yes, for me, it's high quality. But for the end user or the payer or the patient, that will say, hey, how much will that cost? Oh my God, if I want to go and have world-class treatment in the UK or in the US, that's definitely going to be expensive. So again, thinking about feasibility and also thinking about sustainability, because if we just rely on technology, we all know that our mobile phone, I have to change it every 3-4 years. So what about these really big technology that we're going to invest really big money in? I really want to make sure that that investment, I don't have to renew that investment every 5 years or so, or every 3 or 5 years, but I want it to be sustainable so the patient can benefit. Over to you. Thank you, Mark.
Thank you. And picking up on that, Karl, I'd love to hear you. We spent a fair amount of time together, all of us thinking about changes that are necessary down to exactly what's going to happen in certain clinics. And as you hear these words also about cost, can you describe sort of the barriers that you addressed before this and how we address the barriers during this time? And what about the cost perspective of it all?
Yeah, it's a great question. I think the independent of the costs, the barriers I think are in planning or the incomplete info that Eric talked about at the beginning and not kind of knowing what's coming next. And as you shift into operations from planning, really needing to modify the plans as you figure out something that seems like a good idea isn't going to work when it gets down to the front lines. And the inability to control everything. I think Dr. Almaty referenced the kind of need for social interaction. And we've seen our staff become a little less careful about how they interact with each other and what they choose to do outside the hospital, which we cannot control completely, but need to kind of repetitively remind everyone what the risk is, even as COVID surge declines in Eastern Massachusetts here. How we think about cost has been a struggle that we've dealt with prior to COVID, and I think hopefully COVID has actually made us more attuned to this. In some ways, we have to invest in additional technologies, additional staffing, and additional processes that add costs to the system. But what we recognized is that in the United States fee-for-service system, that kind of guaranteed revenue stream is not necessarily there, and there may be more value to shared risk arrangements that incentivize provider organizations like ourselves to take some of the financial and population health risk on for the patients, and would really make us accountable to controlling the costs of care. And we recognize that people are struggling with this, and there's a movement within the United States and really popular opinion across the world that we need to think about how do we make care accessible and efficient and less costly for folks. I don't have a silver bullet for that one, but I think it is something that there are many very, very smart people trying to make sure that we are planning for along all of the other things that we do around here.
Great. Well, thank you. And we have probably time. There's a question that came in, a couple questions from the whole group. I think we'll probably have time picking up on sort of the telehealth theme that's run through all of this. Given how deep in the weeds this panel has been in seeing the amazing transformation, I'm curious about what you think, what is going to happen? And then there was a question asking about collaboration in telehealth. So first, how do you see this in terms of sustainability, in terms of patient care? Do you see other aspects for telehealth? Tell us all what's going to happen 3 years from now. I'll start with Karl. I think you're a great predictor.
Yeah, I wish I knew what's going to happen next month, let alone 3 years from now. But I think from a telehealth perspective, it's here to stay. And we've seen the volume of visits that we've done, that we converted to in April, really maintained over the subsequent months. So I don't think that's going to go down. Patients like it. Physicians have grown to like it. We're going to figure out these thorny questions of how do we integrate it into operations and make it feel efficient and like regular care. And it helps us with things like distancing patients physically and utilizing our space efficiently and making sure patients feel safe. The big unknown is what Dr. Almaty referenced, the kind of payer coverage, because it's unsustainable if no one is paying for it. I have to believe that those in charge of those sort of issues are thoughtful individuals and recognize the benefits of telehealth as well, and will not kind of go backwards towards a situation where you are forced to bring patients in to get paid. I don't think the public will tolerate it at this point, and I think there'll be a lot of pushback from physicians as well. So I think it's really optimizing what we're doing now, and kind of we are setting internal targets of maintaining the volume across this year to make sure that we don't kind of backslide.
And I'll take a thank you. One aspect of this question, we've built, one question was, how do we reach out and collaborate? We've created now, I think, tremendous opportunities in terms of shared decision-making in a compliant way at the Brigham, nationally and internationally, with everybody knows that each zone has their own rules. So we have to be very thoughtful, but how do we collaborate in case conferences, in second opinions, and things like telepathology? Teleradiology has gone on for quite some time, but quite an opportunity here. And we're very pleased at the Brigham to have had the opportunity over the years to have that type of collaboration. So I agree, more to come. So I think we have literally 1 minute left for each of Sawsan. If you could answer first what your thinking is about telehealth, what's really going to happen, and we'll give the last word to Dr. Goralnick.
Well, Mark, it's easy for you to tell me what's the winning number for a lottery than for me to predict what's going to happen in the future, to be honest. I mean, that would be much easier. I can because everything's 50-50, isn't it? Again, 2019 ended and nobody predicted that 2020 will turn out to be like that. But I think, and you can feel it throughout the summit, I think all those individual endeavors, and putting your mind and soul and heart into finding solution that can work for our patient, but also making it institutionalizing it into the hospital, the healthcare facility that you have, and of course having a very supportive leadership. That's really very important. But if the policymaker and the policy is not robust enough, we cannot catch up. They cannot catch up to what we want to do. And I think that is very important. And don't forget telemedicine. We tend, as MDs, we tend to think of patient as a disease. But health is not just illness. It's also attending to mental health. It's attending to my social well-being. It's attending to my spiritual well-being as well. So I think we need to also utilize mental health, to utilize telemedicine to help patients in their mental health issues, which I'm sure is going to be now the biggest issue in the future. Thank you.
Dr. Sawsan, thank you. And Dr. Goralnick, you have 1 minute. You talked about Colin Powell's rule. So you can't actually say that you don't know, because we have 40% of the information. What is the answer, Dr. Goralnick?
Around telehealth? Look, the future is outside of the hospital for healthcare and health. Anyone that's on this in this conference that's a clinician, raise your hand if you haven't practiced telehealth. There should be no hands up, because you're getting texts from family members about, look at this rash, or my uncle has some chest pain, what do I do? We've been doing this for years, and it's actually an art, right? And so we're just at the beginning of this. We're learning how to do a physical exam, take a history in telemedicine. And as one of our colleagues, a gentleman by the name of Lee Schwam, who's a professor at Mass General, it's taken him over 30 years to build a telestroke network to train individuals how to do the art of telemedicine. So we're right at the beginning. There's a significant amount of promise, and we've got to just think differently. And that's one benefit of COVID. It's forcing us to think differently, and it's going to help us provide better care for our patients. Thanks.
Well, thank you so much to the panel, Dr. Madhi. Wonderful to see you, Dr. Goralnick, Dr. Laskowski. Thanks so much.
Well, thank all of you. It's been a wonderful panel. And, I have said there is certainly a silver lining in the COVID cloud, and it may be telemedicine, telehealth, but it's something that I think I agree is here to stay.